We can probably get started. So I am the neuropathologist for the ADRC, and today Vanessa, who is just finished up fellowship and is now faculty here, and Dave, who's faculty in neurosciences, will do most of the presenting of this case that I saw probably we probably got it almost a year ago. This is not an ADRC, like a case with a lot of ADRC clinical history, but the pathology was so interesting, and the case was kind of both unusual in a neuropath sense broadly, and then kind of unusual for its particular diagnosis, that I thought it was interesting enough that we should present it. So Dave is going to talk about the clinical history that we have, and then Vanessa is going to talk about the pathology, and then we hope to have a little bit of discussion about the particular details of this disease, and then some of the things that make this case especially interesting. So I'll let Dave get going on the clinical, and then, yeah, Vanessa, Dave, and I are all going to kind of work on this together. So it's possible that I'll jump back in, or Dave will have some, or Vanessa will have some point they need to make too. All right, go for it, Dave.
Sounds good. I'm going to share my screen. All right, so welcome. So a couple of disclaimers, like Dr. Hiniker had said, this person was not part of the ADRC's longitudinal assessment program. It was an autopsy-only case. I also did not personally care for this patient, so this is all derived from chart review from a number of years ago. But this person was a 45-year-old Vietnamese American woman who presented to movement disorders clinic with about a year of the following symptoms. 1, left upper extremity, stiffness and slowness, also difficulty rolling over in bed and getting out of the chair. It would take her a couple of times to do that. She'd also notice smaller handwriting, but significant lightheadedness on standing, often making her have to sit back down and collect herself, and new urinary incontinence not otherwise explained. Her family history was significant in that her father had passed away at age 86, medical causes, but her mother, interestingly enough, had died at age 69 after a rather rapid cognitive decline that started at age 63. This all happened in Vietnam. We did not know any further details about the symptoms or whatever provisional diagnoses had been made at that time. Her initial exam was confirmatory of the presence of Parkinsonism, but also orthostatic hypotension, and a provisional diagnosis of multiple systems atrophy with Parkinsonism subtype was derived on that first visit, so MSAP. About 3 years after that initial visit, she began to fall. Her PUL test was noted to be positive in the office at that time. She had been trialed on carbidopa-levodopa, and it sounds like that helped a little bit with the rigidity, but it was not a dramatic response and was thus discontinued. It sounds like somebody had also tried ropinirole, which is a dopamine agonist, that also gave a little bit of help with the rigidity. 5 years after the symptom onset, she was wheelchair bound. The Parkinsonism was progressing rapidly. Also, a handful of other features had emerged, including sialorrhea, which was being treated with glycopyrrolate and botulinum toxin injections at that time. 7 years into her disease course, she developed inspiratory stridor, nasopharyngeal laryngoscopy at that time confirmed bilateral vocal cord paralysis, and at that time a tracheostomy was placed. Also during that year, dysphagia was noted, severe enough that it required a PEG tube to be placed as well. About 11 years into her disease course is when we really have the most detailed neurologic exam available to us. At that point, however, she was anarthric, not speaking at all, just squeezing her hands to communicate, able to communicate yes or no adequately, seemed to be appropriate, and was able to follow midline commands, closing her eyes, sticking out her tongue. As far as her cranial nerve and face exam anyway, there was hypomimia. There's possibly slowed saccades in the vertical and horizontal planes and very significant retrocollis, but no other cranial nerve abnormalities were noted. There was severe rigidity in her neck and all limbs, severe bradykinesia in the feet and the hands. Left side seemed a little bit worse than the right side. There was no tremor, neither resting nor action, but there was severe myoclonus of all limbs, worse with action. Sensation appeared to be grossly intact to light touch. There was no noted dysmetria on finger, nose, finger testing. She had an upgoing toe in her left foot, but the right one was mute. Otherwise, her reflexes were not pathological throughout. At that point, she was unable to stand, so gait was not attempted. And an MRI was performed after that visit. So again, she is 56 years old at this point, 11 years into her disease course. I selected a handful of axial T2 flare images for you guys to look at, and there's a handful of things that we can point out. One is severe pontine atrophy with a gliosis here. This is the hot cross bun sign that we see sometimes in people with MSA. You see significant also midbrain atrophy too. When you get up into the basal ganglia, there are these kind of faint rims of gliosis around the posterior putamen. The posterior putamental rim sign is also something you see sometimes in MSA. But globally, there's a fair amount of atrophy for somebody who's 56, and if anything, it seems to affect the frontal lobes a little bit more than the posterior areas, but honestly, everything is much smaller than it should be for somebody this age. Brainstem structures are sometimes better appreciated on T2 without the flare sequencing and without the CSF subtraction. So some of this shows a lot of what I was saying just a little bit more clearly. The hot cross bun sign here across the pons, pretty dilated third ventricle, a lot of atrophy and dilation of the lateral ventricles, ex vacuo. These coronal cuts really nicely highlight how atrophied the caudates are on MRI imaging as well. And then a sagittal T1 image also helps to highlight how severely atrophied her pons is down here. And you can see the cerebellar atrophy, especially on these two lobes here. So one thing that's notable about this case is that she survived a very, very long time in this severe anarthric wheelchair-bound, very rigid state. She survived another 10 years like this, it looks like, getting Botox at our center for filaria and retrocollis about every 3 months or so. She ended up passing away at age 66, a 21-year disease duration ultimately, and her death was related to a pneumonia.
Hey, Dave.
Yes.
For the people who aren't movement disorders people, can you really briefly discuss kind of the differential for this?
Yeah, I mean, so it's not unusual for MSA, but we're going to talk a little bit about this in some of the subsequent slides as well. You know, she presented with a fairly classic presentation of autonomic, very early and severe autonomic problems to go along with Parkinsonism. So your mind either goes to somebody who's got regular Parkinson's disease with severe dysautonomia, which is not uncommon anyway, but you also are thinking about MSA right off the bat on your first visit. However, over the next couple of years, this becomes much more clear because one, she's poorly levodopa responsive, she has rapidly progressive Parkinsonism, and she ends up with a bunch of other extra things. She's wheelchair bound only 5 years into her disease course. That's very unusual for Parkinson's disease. Definite red flag. These other things like inspiratory stridor, cervical dystonias anyway, all of this goes also to MSA. This bilateral vocal cord paralysis thing is relatively rare. However, it is something that we're taught to look out for because it can be acutely life-threatening because of this vocal cord paralysis can cause people, especially when they're sleeping, basically to stop breathing and pass away. Anyway, so occasionally these people will undergo tracheostomy if this particular sign goes on. So kind of a classic presentation in some ways, but the unusual part is that she survived for so long, so severely debilitated. I mean, there is a differential for the imaging findings in isolation. Like MSA isn't the only thing that causes a hot cross bun sign. You know, you can see this in certain spinocerebellar ataxias, but it's much more rare statistically anyway. But this is actually kind of a good segue. So how do this is our most current consensus criteria for diagnosing multiple systems atrophy, although we are anticipating getting a new set of consensus criteria this fall from the Movement Disorder Society. So it's a sporadic progressive adult onset disorder characterized by one, you have to have autonomic failure, which is urinary incontinence and erectile dysfunction in men and some degree of orthostatic hypotension. There's a fairly stringent definition of that orthostatic hypotension, a drop of 30/15 in your systolic over diastolic blood pressure when going from sitting to standing. With that autonomic failure, you should either have poorly levodopa responsive Parkinsonism or a cerebellar syndrome. The poorly levodopa Parkinsonism syndrome is what defines MSAP, and the cerebellar syndrome is what would define MSAC. To be honest, though, most of these people will have a little bit of both, and we really make the call on the phenotype based on which part seems to be more prominent. So there can be a little bit of shifting over the course of their disease. Possible MSA is just if you have the Parkinsonism or the cerebellar syndrome and a bit of autonomic dysfunction that maybe doesn't meet the full, more stringent criteria for probable MSA. And you should also have at least one additional supportive feature. MSA folks often will have upgoing toes and hyperreflexia. We talked a little bit about the stridor also. We already mentioned, like this case had rapidly progressive Parkinsonism, poor response to levodopa, early onset of postural instability. The combination of Parkinsonism and cerebellar features is fairly classic for MSA2. There's some more advanced imaging that sometimes one can get that may be corroborative as well to go along with your structural MRI. Regarding the Parkinsonism in MSA, there's oftenly, although I didn't see notes finding this in this case, if they have a tremor, it tends to be a jerky, irregular postural tremor. It's actually probably polymini myoclonus. They stick out their hands and like the individual fingers go. It's almost like look like they're playing the piano. The UPDRS3 are measures for tracking Parkinsonism in the clinic, worsen's a lot faster in MSA than PD. PD usually gets worse about 10% per year, and it's about 20% per year in MSA. We say that MSA folks are poorly levodopa responsive, but if I think that most of us would still try to use that agent because about 30% of them will show functionally significant improvements, usually early on in the course. It becomes a little bit harder to work with later on, and you're frequently working with this sort of seesaw of treating their Parkinsonism versus exacerbating their orthostatic hypotension. It can be a delicate balance and not one that we're always able to. But here's some other supporting features. Some of these people will have orofacial dystonia, rhizus kind of looking face. That's in the bottom right, a picture of somebody who has that. Disproportionate anterocollis, head coming down to their chest in the panel C above here. Some of these folks will have severe camptocornemia, contractures of their hands and feet, early dysphonia, early dysarthria, cold, ruddy hands and feet are also some things that we see, which belies the vascular changes that happen when the autonomic system is disturbed like this. They shouldn't have significant neuropathy. They shouldn't have visual hallucinations. Those are more indicative of other neurologic phenomena, SCAs and DLB in particular. There shouldn't be much of a family history. MSA does not have any strong genetic associations that have been discovered to date. The dementia aspect is controversial, I would say. I think that there's plenty of other papers that are out there that even now that say that a lot of these people will have significant cognitive impairment, but we just haven't been looking hard enough. And the flavor of cognitive impairment tends to be dysexecutive attentional problems more than anything else. So MSA affects somewhere between 2 and 5 per 100,000 people. Is kind of this interesting disparity that we don't understand, where in Western countries it tends to be 3 per 100,000, but it's more common in Japan and Asia. Interestingly enough, the MSAP phenotype is much more prevalent in the West and Europe, whereas in Eastern countries, MSAC is more prevalent. And this is like a 2/3 to 1/3 split in either place. The incidence does increase with age. You get about 12 per 100,000 over 7 years old or so. The age of onset tends to be in your mid-50s, although there is a range. There are some case reports of young onset MSA for people in their 30s, but there have been no path confirmed cases to our knowledge of anybody under the age of 30 years old. And the average age of survival tends to be somewhere between 5 and 9 years, depending on the papers that you read. But honestly, the range that accompanies those means is very large. Some people have a very precipitous course and pass away only after a few years, but there are plenty of cases that have been documented who survive 15 years. This one's on the longer side, certainly at 21 years also. There's some disagreement about which phenotype maybe harbors the worst prognosis, but generally the more severe your autonomic failure is and your functional disability is, the worse you tend to do anyway. Unsurprising, I think. And men and women are affected at equal rates, which is in opposition to the other synucleinopathies like PD, where there's a male predominance. So challenges in clinical diagnosis also. There's a handful of classic clinical pathologic papers who have tried to examine our diagnostic accuracy of assigning an MSA diagnosis during life. Classic ones like Hughes from 1992 and 2002. The general gestalt of this is that MSA and PD are probably the most commonly confused ones anyway. You know, there's some older literature with some very poor clinical pathologic associations when we're trying to assign MSA diagnosis, but honestly, a lot of the more recent ones, we get closer to the 80 or 90% range anyway. We do better with our accuracy the longer that we know the patient, and also if they have some of these extra supportive features, especially the levodopa responsiveness and the autonomic features anyway. So basically, the longer that you know the patient, the longer you can sort of follow them and make sure that they fall into a classic phenotype, the better you are anyway. But still, I think that many of our movement disorders people would agree that it still can be challenging to tell a Parkinson's disease patient who has severe autonomic dysfunction from a MSA patient anyway. It can be tricky. That being said, there are some biomarkers that can maybe help us a little bit. So, you know, MSA folks do have a little bit of hyposmia, but it's somewhere in between the hyposmia that we see in controls. It's just worse than Parkinson's disease. And even though we have about 80% of people with MSA at some point in their course will have REM sleep behavior disorder, if you take a prodromal cohort of people with REM sleep behavior disorder, like the Ron Postuma and those guys in Canada have done, and some other groups too, the majority of them will turn into other synucleinopathies, PD and DLB, but only about 5% of them will convert to MSA if you follow them for long enough. There may be some biofluid biomarkers that may help you differentiate Parkinson's disease from the atypical Parkinsonian syndromes. We talked a little bit about neurofilament light chain, which can now be done by CSF or by blood. And you do see, at least group-wise, higher elevations in MSA than you do in PD or controls anyway. This is neurofilament light chain, as I think all of you guys have probably heard before, is a non-specific marker of neuronal damage. So as such, it's elevated in all the other atypical Parkinsonian syndromes as well, where the neurodegenerative tends to be more brisk. And then something that we can't avoid talking about are the synuclein aggregation assays, the RT-QuICs and the PMCAs that are really taking sort of center stage in the PD and DLB world as being some of the most sensitive and specific assays at identifying these people, sometimes very, very early on in the course of the disease. Can they identify people with multiple systems atrophy? The answer is probably, but it's a little bit trickier, actually. So the sensitivity and specificity is not quite as good. And this big panel that I'm showing you at the right anyway, is actually showing that they tend to achieve like lower levels of fluorescence in general than your MSA. And this actually probably has to do with the synuclein conformers that they are trying to measure in the CSF anyway. The bottom two rows anyway, E and G, is showing the fluorescence by using these different thioflavin tagged markers, trying to get them to stick to the seeds that they have derived from these patient samples. And the one on the top seems to work better for your classic Lewy body disease, your PD or your DLB, whereas the one at the bottom seems to do a bit better for your MSA. So while these are both synucleinopathies, your Lewy body disease and your MSAs, the biology and the conformational structure of the synuclein that you see is significantly different enough that it appears to mess a bit with the synuclein aggregation assays. This ultimately just means that we need to tune this a little bit more specifically for MSA, and that what works for PD isn't going to work for everybody. And then imaging biomarkers, structural imaging like MRI, we do see this hot cross bun sign. You can also see the putaminal rim sign. Here's some more examples of it. Putaminal rims on this person here. Sometimes you'll also see gliosis of the middle cerebellar peduncle, MCP signs, highlighted in this G in this panel here. These tend to be specific but not sensitive. They're not terribly useful in early disease. People tend to be phenotypically defined by the time they exhibit these findings on MRI. And then another thing that's a little bit perhaps more useful but less obtained in this country is something called MIBG scintigraphy, which is a nuclear medicine scan with a tracer that binds to the post-synaptic, autonomic innervation of the heart, actually. So interestingly enough, in Parkinson's disease and DLB, you get presynaptic and postsynaptic denervation on the autonomic system, whereas in MSA, it's almost exclusively on the presynaptic side. So consequently, in MIBG scintigraphy, MSA people have preserved heart signals, whereas in PD and DLB, they actually have decreased heart uptake. And you can see, and this is a classic paper from a few years ago, as people go on with their Parkinson's, that their cardiac uptake actually decreases. DLB also has very, very low cardiac uptake, usually from the get-go, whereas MSA is much closer to normal just because of the nature of the autonomic denervation that you see. So those are some things that can help you differentiate these things potentially during life. That's all I got. We're going to go on to pathology next. Unless
David,
yeah,
I think there was at least one paper back looking at midbrain pons ratio. I don't know if you have anything on that, but they basically were looking at the differentiation between PSP and MSA using midbrain pons atrophy, just and then taking a ratio. It was really kind of crude. They were just drawing a line across the sagittal, but one could imagine one could do that better, but just looking at the different atrophy patterns of the brainstem, something that you might see.
Yeah, that's absolutely right. And there's some ongoing work with that too. That's called the MRI Parkinsonism Index. It's Doctors Quattrone and Villain-Court have been sort of pioneering that for the last couple of years. They've used a handful of different ratios, looking at midbrain to pons, superior cerebellar peduncle to middle cerebellar peduncle. And yeah, the ratio is especially good at telling PSP from PD. MSA tends to go in the other direction, since the pons is the one and the middle cerebellar peduncle is taking the hit, and just how the ratio goes. But a lot of their literature is a little bit more robust at telling PSP from other things. There is actually we're a site for this upcoming MRI study too. Dr. Litvin and Eche Bayram are leading the recruitment efforts for this, but it's one of Dr. Villain-Court's studies where we're trying to get very high resolution structural MRIs in our undifferentiated Parkinsonism patients, and using some of these volumetric, it's not really the MSA or the MRI Parkinsonism index, it's some other volumetric pons to midbrain ratio to help predict who we think is going to have MSA, who we think is going to have PSP, and who we think is going to stay as PD anyway. It's all some type of volumetric machine learning proprietary stuff that they're doing, but yeah, it is evolving, and we are participating in that, so that's exciting.
Great, thanks.
David, do you think there's a role for DAT scanning at all?
Oh, that's a good question. I thought about putting a DAT scan slide in there, but I wasn't sure I'd have the time to talk about it. So DAT scanning.
Apologies then.
Okay, so but as I think you guys also know, but DAT scan is not perfectly specific for Parkinson's disease. It really is positive in anything with striatonigral degeneration anyway. So I have had many patients will be positive. In fact, the majority of them will be positive anyway. But if you have somebody with a very large cerebellar phenotype anyway, it's not, there are case reports of people having a normal DAT scan in MSAC who are then go on to be autopsy proven. Now, usually those DAT scans are obtained fairly early in the disease, and the data is cross-sectional and not longitudinal. But yeah, ultimately one could, but it might not help a ton with differentiating during life anyway. It really would have to depend on the clinical scenario that you were taking it. But I personally have tried to get DAT scans on a couple people who had cerebellar syndromes, and I was not sure whether I was going to deal with MSA or maybe a cerebellar ataxia genetic syndrome anyway. I think it's helpful in that scenario if it's positive, but not so helpful if it's negative ultimately.
Thanks. All right, if there's no other comments or questions, we'll go on to the pathology. So just to recap, the patient had a disease course of about 21 years. At first visit, she had a diagnosis of MSA, and we received the brain about 6 months ago. So Vanessa? So Vanessa's gonna talk through, she had the clinical diagnosis of MSA. We're still going to talk through kind of when we receive a brain at the ADRC, the standard stains we do and kind of what they may show.
Yeah, so first I'm just going to go through the types of pathology we would be looking for in any of these brains we receive. So of course, we look for evidence of Alzheimer's pathology, which would include the tau tangle. So we have a nice neurofibrillary tangle here on H&E and also highlighted on the tau IHC with some background gliosis as well as a plaque. And of course, in Alzheimer's, that goes along with the beta amyloid plaques, which we see numerous of in this section of neocortex, as well as some amyloid angiopathy. So amyloid in the vessel walls here. As we just talked about, there's a lot of overlap with MSA and Parkinson's disease. So we're going to be looking for evidence of alpha-synuclein pathology, which would include Lewy body pathology and Parkinson's disease. So here we have a healthy patient with a nice pigmented substantia nigra versus a Parkinson's disease patient on the right with significant pallor and loss of those pigmented neurons in the substantia, which we also see the correlate of histologically on the bottom, where you have severe loss of those pigmented neurons compared to the healthy patient on the left. And the remnant neurons have Lewy bodies, so these eosinophilic cytoplasmic inclusions, which would be alpha-synuclein positive. That's in contrast to multiple system atrophy, which is also alpha-synuclein accumulation, but has different correlates to the inclusions on alpha-synuclein staining. So grossly, in this patient with MSA, we can see there's not much in the way of cortical atrophy, but there's this very characteristic discoloration of the lateral putamen. And in MSA, the alpha-synuclein tends to be in glia. So you get glial cytoplasmic inclusions, which are the characteristic finding kind of pathognomonic for MSA, in contrast to Lewy body disease or Parkinson's, where the inclusions are predominantly neuronal. So in MSA, you get these glial cytoplasmic inclusions, which are in oligodendroglia here on the left, and you can also get some neuronal inclusions shown here on the right, a neuronal cytoplasmic and nuclear inclusion. And because this patient did have some global atrophy, including frontotemporal kind of predominant atrophy, we'll look for other evidence of possible frontotemporal dementias like a TDP-43. So what we look for there is nuclear to cytoplasmic translocation of the TDP-43 protein. So you can see here this nucleus is negative and we have a nice rounded cytoplasmic inclusion. Or something like a Pick's disease where you get tau positive Pick bodies, which are shown here, which would be 3 repeat tau, these cytoplasmic inclusions of Pick's disease. So now we'll move on to the patient's pathology, starting off with the gross examination. So the brain was quite atrophied just by weight. So it only weighed 852 grams. A normal, adult female brain should be somewhere between 11 and 1300. So quite a small brain. And we can see there is global atrophy, as was mentioned on the imaging, but most severe in the frontal lobe, where you can see pretty severe widening of the sulci and narrow gyri here in the frontal cortex. From the medial view of the brainstem, we can see the pons looks quite small. There's severe atrophy of the basis pontis and also atrophy of the cerebellum. And I didn't show it here, but on cross sections, there was pallor of the substantia nigra and locus ceruleus. On coronal sections, again, we see pretty severe cortical atrophy. There's some thinning of the cortex and a lot of white matter loss in the cortex, as well as severe hydrocephalus ex vacuo. So these are very large ventricles here. And there was severe atrophy of the basal ganglia, particularly the putamen and globus pallidus, with relative sparing of the thalamus. And also the hippocampus, both anterior and posterior, were quite small. So next we'll move on to the histology, starting off with just our standard H&E staining. So this is a section of middle frontal cortex. We can see there's a bit of gliosis in the molecular layer and a bit of vacuolization in layer 2, but not really severe neuron loss. Here's just a higher power view showing you a bit of vacuolization and this kind of amorphous eosinophilic thickening of some of these vessels, suspicious for possible amyloid angiopathy. What was much more impressive than the cortex was the underlying white matter. So this is a section of subcortical white matter from the middle frontal region, where you can see there's severe pallor and rarefaction. It's almost microcystic in this area with abundant gliosis. There's a section of superior temporal gyrus. Again, not much neuron loss. There's nice neuronal populations throughout this cortex, but we can start to pick up a few plaques here in this section. But again, the underlying white matter, which I didn't show here, was rarefied and pale. In the cerebellum, similar to what we saw in the cortex, was again severe white matter pathology. So this white matter is very pale and gliotic. The overlying folia themselves, we have molecular layer, Purkinje cell layer with Purkinje cell dropout, and the internal granular layer, perhaps a bit of Berkman's gliosis. But what stood out here was the white matter changes. And here we're in the posterior hippocampus. So this is the dentate gyrus here. And in the CA areas, particularly CA1 and CA4, there was neuron loss and gliosis. So this is a higher power view from CA1, where you can see some neuron dropout. And the basal ganglia, as we suspected based on their gross appearance, had severe pathology. So again, this is almost microcystic, the severe rarefaction and pallor of the basal ganglia with extensive neuron loss and gliosis, as well as some vascular pathology. So here's a higher power view, again, showing you just severe gliosis, only a few remaining neurons, and significant white matter loss. And the substantia nigra, as I noted grossly, was pale, and corresponding to that, we have significant loss of the pigmented neurons here. And again, it's kind of this surrounding pallor. And in the basis pontus, again, significant neuron loss within those basis pontus nuclei, which corresponds to the atrophy we noted grossly. And one more thing I wanted to point out on the H&Es was in the posterior amygdala, there were a few neurons that had these kind of rounded cytoplasmic inclusions. We can see here and here, maybe another one down here, that resemble PIC bodies. So kind of rounded eosinophilic cytoplasmic inclusions in the posterior amygdala, which we'll come back to when we get to some of our immunohistochemical staining. So next we'll move on to looking for evidence of Alzheimer's disease with our IHCs. So we'll start by looking for amyloid plaques for the thal phase using our beta amyloid stain. So here's the amyloid in the middle frontal cortex. We can see there are plaques in the cortex, as well as amyloid angiopathy, as we suspected on the H&E. And there were more abundant plaques, again, in the entorhinal cortex, and also some beta amyloid deposition in the cerebellum, which gives us a thal stage of 5. And next we'll look at our Brock staging, which we do by doing tau staining for neurofibrillary tangles. So this is a tau in the middle frontal cortex, and you can see there's no tangles at all. So it's completely negative in the middle frontal cortex. And I didn't show it, but there were very rare tangles in the superior temporal gyrus. However, in the entorhinal cortex and layer 2, we can see there's clusters with quite a few neurofibrillary tangles, which were also present throughout the hippocampus. Here we can see them at CA1 extending to the subiculum. So overall, the thal stage was 5. We gave it a Brock 2, and there were few neuritic plaques, so just a C1, so that led us to a low likelihood of Alzheimer's or low ADNC staging. So this is just the summary of the Alzheimer's staging, again, with the thal 5, Brock 2, and CRED 1. So as we talked about clinically, this patient had a diagnosis of multiple systems atrophy and some Parkinsonian signs. So we'll look for evidence of alpha-synuclein pathology next. So we'll start off in the midbrain, and this is our alpha-synuclein IHC, and you can see there's maybe one cell here with a glial cytoplasmic inclusion. And these were very hard to find, only a few on the whole section of midbrain. And for MSA, you would typically expect to find more of these cytoplasmic inclusions, but just the one here. And then we were also able to identify some alpha-synuclein pathology in the basal ganglia. So here again, these more like kind of ring-like inclusions and perhaps a nuclear inclusion here on the left. But the synuclein pathology was quite sparse in the areas you typically expect for multiple systems atrophy. So this was actually confirmed with several different alpha-synuclein antibodies, I think 4 different stains, and all of them showed very sparse synuclein pathology in the brainstem and basal ganglia. We were able to find some neuronal cytoplasmic inclusions, for example, this one here in the inferior parietal cortex. And here's a nice example of a glial cytoplasmic inclusion in this oligodendrocyte in the cingulate gyrus. And so this glial cytoplasmic inclusion is kind of pathognomonic for multiple systems atrophy.
So I just want to jump in and say, I guess we should have shown like typical MSA, but typical MSA in these regions, maybe not so much cingulate, but brainstem, basal ganglia is florid. It is nothing like Parkinson's pathology where you're kind of hunting for Lewy bodies here and there. It's in like a large percentage of the glial cells. So this was something that was super interesting to me. It was that like we see this devastated brain and it looks kind of like MSA, but not completely like MSA. Like the cortex is much worse than we expect. The hippocampus is much worse than we expect. Yet when we do the synuclein staining, and because I didn't really, I wasn't sure about it, we did a lot of different synuclein stains. Dave actually physically did 2 of the stains. We sent it up to Canada to get another stain, and they were all very sparse synuclein inclusions, except in some regions that Vanessa, I think, is going to talk about in a little bit. And so that's the pathology point that's like one of the pathology points that's unusual and interesting, is that like it looks kind of like MSA grossly, but not totally. And microscopically, where is all the synuclein? Okay.
And the glia are still present, or are they kind of burnt out and gone? They're still there.
Oh, that's a good point. I think some of them are actually gone. You're totally right. Because there was so much astrogliosis. Oligos, yeah, you're right. Like I would say a lot of the oligos were actually probably gone. But it wasn't like we couldn't find any oligos and therefore we couldn't find any synuclein. It was like there were oligos, but there wasn't much synuclein. But I think that point is very interesting. Yeah, because we had obvious loss of brain substance, as Vanessa kind of showed on the H&Es.
In Alzheimer's disease, when the neurons disappear, the taus stick around for a long, long time as ghost tangles. Does synuclein do the same thing, or is it more likely to be absorbed?
Dave, do you actually know? I don't actually know. We can see synuclein, like, and maybe Larry behind Vanessa can answer this better. We do see synuclein, like Lewy bodies, sitting out, not in cells. But as far as like after a very, very long time, I don't know. Larry, do you have a comment?
I see where you're going with this. I mean, the hypothesis now seems to be that, well, it was a severe MSA, but all the inclusion-bearing oligodendrocytes have died and gone away, and so you can't find the body, so you can't prove that there's a murder. I guess, and maybe that's reasonable to think about because it normally doesn't last for 22 years. So all the MSAs that we're used to looking at are people that are more in the range of 5 to 10 years. So maybe if you lay it for 20 years, all the cells that are affected are dead and gone. I guess I've never seen an MSA with that long a survival, but in the ones that I've seen, as you said, it's much more florid and there's alpha-synuclein in the expected locations in abundance.
And yeah, that was kind of one of the weird points we wanted to make about this case clinically. I think Dave highlighted it really well, just that this woman essentially had so much medical intervention to keep her alive. Like she had the trach, she had a G tube, and we didn't mention it, but she had like a very, I think a spouse in the medical profession who like essentially kept her going way longer than most people would last. So yeah, whether this is kind of unusual in that it's so end stage. Vanessa, you want to keep going?
Sure. So as Dr. Hiniker alluded to, there was one area where we did see more alpha-synuclein pathology, which was not the typical regions of the brainstem or basal ganglia. It was actually in the entorhinal cortex and in the hippocampus. So here in the entorhinal cortex, we can see some neuronal cytoplasmic inclusions on alpha-synuclein. Here's a nice higher power view of kind of a flame-shaped neuronal cytoplasmic inclusion. And this was also seen in the hippocampus, in the dentate and CA1 areas. So here in the dentate, we see these fairly abundant kind of ring-like cytoplasmic inclusions in the dentate granule layer, which were more abundant on alpha-synuclein than they were on our Gallia silver stain, which is interesting, as it's typically been reported that the inclusions in multiple system atrophy are positive for Gallia silver, but there's clearly some disparity between these two staining techniques where the synuclein antibody is picking up more inclusions than the silver stain, and we'll come back to that later. And that was also seen again in the hippocampus in CA1, where we see fairly abundant neuronal cytoplasmic inclusions, some of these kind of more tangle-like or flame-shaped, and some ring-like structures, which were fewer and harder to find on the Gallia silver stain, just showing one nice tangle-like structure here. And curiously, there was kind of the opposite pattern in the subcortical white matter that we saw was pretty devastated on H&E. And on alpha-synuclein, we could pick up some of those glial cytoplasmic inclusions here, but they were much more abundant on the Gallia silver stain than what we saw on the antibody stain. And then lastly, on the IHCs, I just wanted to go back to those pick body-like structures that we saw in H&E in the posterior amygdala. And so when we did our antibody staining, we can see that some of those pick body-like cytoplasmic inclusions are positive for alpha-synuclein, but some of them are also positive for tau. So they're staining for both antibodies. So the final diagnosis on this case was multiple system atrophy, but we saw that this had a very peculiar pathology. It didn't have the usual abundance of glial cytoplasmic inclusions in the brainstem and had more of this limbic predominant synuclein pathology, which we'll come back to. And again, this low ADNC for Alzheimer's disease staging. And I didn't show it, but there was no evidence of TDP43 or FUS pathology to explain any of the frontal temporal atrophy. So just again, to go over kind of the standard pathology for multiple systems atrophy and why this case doesn't really fit our expected findings. Of course, it differs if you're looking more at MSAC, which corresponds to olivopontocerebellar atrophy, or MSAP, which is striatonigral degeneration. But you can see in either case, most of the time, the cortex is not severely affected. In the MSAC, you tend to get severe atrophy of the middle cerebellar peduncle and cerebellar white matter, as well as severe atrophy of the basis pontis, which is shown down here. In contrast, in MSAP, the middle cerebellar peduncle is relatively spared, as well as the basis pontis, but you have pallor of the substantia nigra, and in both cases, you can get that discoloration and atrophy of the lateral putamen compared to the control case on the right. And histologically, that corresponds to, of course, neuron loss and gliosis in those regions. Here in the substantia nigra, in panel F is in the basis pontis, and G is showing severe neuron loss and gliosis in the basal ganglia, with the inset showing iron accumulation, which is also quite typical of MSA. And this is a more typical case of what we would expect to see in these bottom panels on IHC for alpha-synuclein. So these abundant glial cytoplasmic inclusions, which were very few and far between in our case in the brainstem. And then some of the neuronal inclusion morphologies, you can see again, the more ring-like, pick body-like, or flame-shaped. But more recently, there's been several reports of something termed atypical MSA. And so this report here was 4 cases of patients with pathologically proven multiple systems atrophy. However, they were noted to have significant frontal and temporal cortical atrophy, which again is not typical of standard MSA. So here you can see atrophy of the frontal and temporal cortex. And pathologically, what they found in these 4 cases is that they had limbic predominant alpha-synuclein pathology. So similar to what we saw in our case, where there were less prominent alpha-synuclein staining in the typical regions of the brainstem and basal ganglia, but more prominent findings in the limbic areas like the basal ganglia, or sorry, like the dentate gyrus shown here, as well as the subiculum and the amygdala. And they also described that there were more neuronal inclusions rather than glial cytoplasmic inclusions. And those included these ring-like inclusions in the dentate and these pick body-like inclusions here shown on H&E and on synuclein staining. And so this here is showing 2 of these cases in the different stains. So the alpha-synuclein stain, the Gallius silver stain, and the tau. And you can see that no matter the type of inclusion, they all seem to stain pretty strongly for alpha-synuclein and Gallius, including in the dentate and subiculum, as well as the frontal cortex. And one of these in the dentate fascia had those pick body-like inclusions, and similar to what we saw in our case, they stained not only for alpha-synuclein and Gallius, but they also stained for tau. And so they compared these 4 cases of what they termed atypical MSA to 34 cases of typical MSA. And they found there was no significant difference in the age at death, the age of onset, or the duration of the illness, but there was a significant difference in the scoring of the pathology, particularly the neuronal cytoplasmic inclusions on alpha-synuclein staining. And that difference was found in 3 regions: in the hippocampus, in the dentate fascia, CA1 in the subiculum, and also within the hypothalamus. And so when they went back and looked at the clinical features of these cases, what they found were that all 4 cases had clinical features of more of a frontotemporal dementia syndrome. So 2 of them had been clinically diagnosed as corticobasal syndrome. 1 had been diagnosed as a progressive non-fluent aphasia, and 1 was diagnosed with a behavioral variant frontotemporal dementia. So they had actually proposed, rather than calling this atypical MSA, that it should be termed frontotemporal lobar degeneration synuclein to fit in with the FTLD classification scheme. And this isn't the only report of these so-called atypical MSAs. There's been several case reports out of Japan of very similar cases. So here, for example, there was an autopsy case of long-standing MSA with severe atrophy and more abundant neuronal cytoplasmic inclusions in the temporal lobe. Another case, again, with massive neuronal inclusions and temporal lobe atrophy. And here a case where, again, they describe this co-localization of the synuclein and phosphorylated tau in these inclusions in a patient with long-standing MSA. And this was one more study out of Japan, where this was just a review of 102 pathologically confirmed cases of MSA. And they found that 2 of these cases kind of fit into this atypical MSA scheme, where there was severe frontal and temporal atrophy, which is atypical for MSA. And both of these cases, curiously, had a very long disease course, 1 15 years and 1 for 25 years. So kind of similar to our patient in the longer disease course. And again, the alpha-synuclein pathology was more predominant in the limbic structures, as we saw in our case. And there were more abundant neuronal cytoplasmic inclusions rather than the glial cytoplasmic inclusions. So just to kind of summarize the differences between MSA versus now it's being termed atypical MSA clinically, of course, typical MSA, you have those predominant motor features, whether they're more Parkinsonian or cerebellar, and then the autonomic features. An atypical MSA, in some of these cases with that pathologic pattern, they have had autonomic and motor features, but others, as we saw in that case series, present more with a frontotemporal dementia. And several of the cases, particularly from Japan, have reported this longer disease course in these cases that fit with atypical MSA. And then pathologically, again, in your standard MSA, you expect minimal cortical atrophy and much more prominent brainstem and cerebellar pathology, including those glial cytoplasmic inclusions, versus the severe frontal and temporal atrophy in atypical MSA with that limbic predominant synuclein pathology and a greater abundance of neuronal inclusions instead of the glial cytoplasmic inclusions. And then lastly, we just wanted to go back and kind of discuss this disparate staining between the alpha-synuclein and our silver stain or Gallius staining. So again, as we saw in the subcortical white matter, the alpha-synuclein picked up a few glial cytoplasmic inclusions, but they were much more abundant on the Gallius stain, which was the opposite in the dentate, where there were these abundant ring-like inclusions on synuclein, IHC, but only a few on the silver staining. So why are these kind of stains having such different sensitivities for these inclusions? So we know that although these are alpha-synuclein inclusions, there can be differences in their conformation as suggested here, where we know both Lewy bodies and glial cytoplasmic inclusions of MSA are alpha-synuclein aggregates. However, Lewy bodies are known to be negative for Gallius silver, whereas glial cytoplasmic inclusion are positive on silver staining, strongly positive. And so that suggests perhaps there's different conformations to these alpha-synuclein aggregates in these different cell types that leads to the different sensitivities of these stains. And this was further suggested by this recent paper where they actually developed a series of novel antibodies targeting a different region of alpha-synuclein than the standard IHC. And when they used these new antibodies on cases of pathologically proven multiple systems atrophy in the brainstem, they identified abundant neuronal synuclein pathology in contrast to the glial pathology that had not previously been reported. So typically, as we've talked about, the glial cytoplasmic inclusions are the most prominent finding in the brainstem of patients with MSA, but perhaps these neuronal inclusions were just being missed due to the sensitivity of these antibodies. And that again suggests that perhaps the different inclusions in neurons or glia have different compositions of alpha-synuclein, leading to this differential staining pattern. So in summary, this case, the pathology fit best with atypical multiple systems atrophy due to the frontotemporal atrophy, the limbic predominant pathology. It's a bit unusual because our case, as we saw clinically, met criteria for MSAP and didn't have any clinical evidence of frontotemporal dementia, although we did have limited clinical data and she was anarthritic, perhaps limiting evaluation of that possibility. And despite her very long disease duration of 21 years, there is very sparse alpha-synuclein. And then that disparate staining between our alpha-synuclein and the silver staining suggests that maybe these different inclusions have different conformations with variable immunoreactivity. So I think we'll leave it there for discussion.
All right, well, thank you, everybody. Thanks, Vanessa and Dave, for doing the bulk of the presenting. And next time we'll try to do one that has a bit more ADRC relevance. And I think I have a good one lined up. So thanks.